Good afternoon, and thank you for joining the RLS Foundation's webinar titled Case Studies, Advanced Management Strategies for Severe RLS. My name is Carla Diezenkowski, and I'm the Executive Director of the RLS Foundation. The 2025 educational webinar series is an official RLS program that addresses integral topics related to restless leg syndrome community through expert-led webinars. The RLS Foundation is using Zoom for this program. To ensure a seamless viewing experience, confirm that your Zoom Workspace app or browser software is up to date to meet Zoom requirements. Following the live webinar, the recording will be available in the member portal of our website. If you would like to view this webinar recording but are not a Foundation member, we invite you to join online today by visiting rls.org. Please be aware that all attendees will remain on mute during this hour. Following the presentation, the speaker will answer as many pre-submitted questions as time allows. As always, individuals suspecting that they have RLS should consult a qualified healthcare provider. The information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a physician. All content shared during this webinar are the property of their respective creators and such are protected by copyright. They may not be reproduced, distributed, or otherwise used in any fashion without the creator's permission. Our speaker today is Dr. William Ondo. Dr. Ondo serves as the director of the Movement Disorders Clinic at the Houston Methodist Neurological Institute, a certified RLS quality care center. Dr. Ondo has written over 300 articles and book chapters throughout his career. A movement disorder specialist, he is board certified in adult neurology. Dr. Ondo's research specializes in Parkinson's disease, essential tremors, and the use of botulism toxins in the treatment of movement disorders and, most importantly, restless leg syndrome. At the RLS Foundation, Dr. Ondo is an active member of the RLS Foundation Scientific and Medical Advisory Board. Thank you, Dr. Ondo, for your time and expertise with us today. I now invite you to begin your presentation.
All right, thank you, Carla. Pleasure to be here. Hope everyone's having a good day. So I was asked to discuss sort of the more challenging cases, and I'm gonna start with a couple of caveats here. Okay, first of all, I'm gonna show about 4 vignettes to make a bunch of different points about challenging cases in RLS. Now they're all just composites of cases I've seen, although many of you may, they may sound very familiar to yourself if you're in this category of people who've tried the usual things. My second caveat is just sort of an explanation about the quality of the information I'm presenting here. So in medicine, we like proof. You like a medicine to show benefit compared to a placebo where no one knows what they're on, and you have that very, very hard data, okay? Almost everything I'm going to discuss lacks that sort of scientific proof. Okay, these are all steps kind of beyond the standards. We know that pramipexole is better than a placebo for standard RLS, but there have been very, very few studies, almost no studies at all, in what do you do after the standard treatments for restless legs. So just about everything I'm going to tell you here is my opinion. That opinion's based on a fair amount of experience, but it is still my opinion. And I want to emphasize that there are other people that are outstanding RLS experts that might do things or recommend things a little bit differently because we just don't have the sort of scientific studies to tell you what to do after someone has failed pramipexole or something like that. Okay, so those are my caveats. The 4 cases I'm going to read verbatim, okay? And like I said, these are just sort of composite cases. The first one is the most straightforward case in a way. 58-year-old woman diagnosed with familial RLS for at least 16 years. For the past 6 months, she's been treated with stable ropinirole. We'll pick on ropinirole on this one, 2 milligrams at 6 p.m. and 2 milligrams before bed. Aside from occasional nausea, she's tolerated this very well and historically has had very, very good control, almost complete amelioration of symptoms on this. However, Recently, just starting about 2 weeks ago, she has had a fairly sudden worsening or exacerbation of RLS at night. There's no change in the time of when the symptoms are occurring. They're just happening at night like they used to before treatment. But the ropinirole just doesn't seem to work very well. Other past medical history, clue here, is significant for increased cholesterol and seasonal allergies. So this case I actually have copied from cases that I've presented to physicians. So we have this thing, well, what's your additional information? What else do you need here? But we'll skip that question in this format and just talk about things that can acutely change RLS. So you're just doing swimmingly, you're doing great, then boom, all of a sudden you have a sudden change in RLS. So that means something happened. Okay, so there's some change that's gone on in place. That's not like gradual augmentation, which we'll discuss here shortly. So things that come into mind are these. So there are medicines that worsen RLS. Okay, was a new medicine started, either prescription or, as we'll see, over-the-counter medications can worsen RLS. All right, and we'll get back to that. Another thing we would look for an acute change or an acute worsening of RLS, is there any reason to be more iron deficient? Now, usually, if it's acute, this is going to be blood loss, okay, including blood donation, you had a surgery, or blood, occult blood loss means we don't really know why it's there, like a GI bleed. So this has actually been on neurology boards, which I think is a great question of a similar vignette here, or someone with acute worsening of RLS, and the answer was GI bleed. So they had colon cancer and were bleeding, and because of that, the RLS worsened, okay? Other things that we would look for are simply just changes in life circumstances. So has the circadian clock changed? Have you gone to a different time zone where their sleep cycle doesn't really jive yet with when the RLS biologically would occur? Is there any other cause of worsening sleep? Because if you're sleep deprived and tired, RLS will get worse. Now, as you can imagine, if the RLS gets worse, then your sleep gets even worse, and this can spiral downwards as something that worsens the overall RLS, but maybe even started with some other cause of sleep deprivation. Okay, so these are the things that come to mind mostly for an acute change, other medicines that can worsen it, iron loss, blood loss, and then change in circadian structure or some other reasons to be more tired. Even exercise, extreme exercise, which I wouldn't discourage, can in some cases worsen RLS because it makes you more tired. Anything that makes you want to fall asleep, like a good workout in the day, can potentially make RLS worse. Okay. So these are things we think of. Let's get back to the first one, medicines that would worsen RLS. So what are these? Well, dopamine blocking medicines. So these often are psychiatric medicines, but sometimes nausea medicines like compazine, Phetergan, Reglan, metoclopramide, these sorts of medicines that can worsen RLS. What's interesting to many of us is they don't always worsen RLS, because dopamine medicines that mimic dopamine, very robustly initially treat RLS, but dopamine blocking medicines that do the exact opposite sometimes will worsen it, but not always. Okay. Certain antidepressants, in fact, most antidepressants can increase the leg kicking, the jerking part, what's called periodic limits of sleep. But there are certain antidepressants that also have the third category, antihistamines, such as mirtazapine. That's an antidepressant medicine used as a sleeping pill, but it's a very strong antihistamine. And antihistamines really are the big ones that commonly worsen RLS. The ones that tend to do it are the sedating sort of antihistamines, and they are sedating because they get into the brain. So cross the BBB means cross the blood-brain barrier. The brain is very protected from the rest of the body. It doesn't like a lot of chemicals going around it. If everything that was in your blood gets to your brain, we'd probably be in a coma all the time. So there's this blood-brain barrier which protects the brain from many things. Sedating antihistamines are ones that cross the blood-brain barrier. So I actually made a list of antihistamines, and the ones that are underlined here are all over the counter. Okay, And sometimes it's obvious you're taking an antihistamine, okay, like, Benadryl for allergies, but antihistamines are used for other things like itching medications, okay? I mean, they are used as sleeping pills flat out. And they can be marketed different ways and say different things on the bottle. But all these underlying antihistamines are non-prescription medicines. Doxepin at the bottom is a sleeping pill. Okay, that's just a pure antihistamine as far as the sleeping point. Mirtazapine, we mentioned, is usually used as a sleeping pill. Prescription medicines. Hydroxyzine is usually used as an itching medicine, but they're all antihistamines. The ones that probably are the worst are these ones on the top that cross the blood-brain barrier with three X's here or three crosses. Diphenhydramine, which is Benadryl, and many nighttime sleeping medicines is probably the worst. Okay, what's the best? I mean, if I need an antihistamine, well, again, there is no scientific data studied looking at this, but in theory, fexofenadine is probably the best antihistamine to take to not worsen RLS. Xyzal is probably pretty good, and loratadine, which is a common one, Claritin as a non-sedating antihistamine, is probably okay. So those are probably your best three antihistamines if you absolutely need one, if you do have restless leg syndrome. Okay. Next case. Okay, next case. All right, this is a little bit of a different case. A 60-year-old male with a 25-year history of restless legs, currently taking pregabalin or Lyrica, 300 milligrams at night. RLS is actually pretty well controlled. 6 out of 7 nights, no RLS. Occasional breakthroughs in the middle of the night, which will waken him maybe one night a week. But he doesn't have RLS during the day, but he is exhausted. Okay, he complains, I'm just sleepy all day long. So what do you do here? This certainly comes up. Patients where seemingly the RLS is fairly well controlled, but they're still having consequences of the RLS during the daytime manifest by sleepiness or fatigue. So the first issue is to try to sort this out. Is it really sleepiness or is it more fatigue? Is it maybe a lack of motivation or depression? Are you lightheaded when you stand up, which sometimes people might consider more fatigue? Is there a physical weakness? So these symptoms can overlap, but they can have different causes. I mean, sleepiness is usually caused by sleep deprivation or medicines that make you sleepy during the day. Fatigue, wow, I mean, there's a zillion things that can cause fatigue, medical problems, psychiatric problems, depression can cause fatigue. So you have to try to sort this out as best you can. And we spend a few questions trying to, what do you mean by I'm tired during the daytime? So that's an important thing to try to sort out. So the first thing is, are you sleeping well at night? So maybe they're not having much actual RLS symptoms at night that they're aware of, but for some other reason, they're not sleeping. Now, this is the one scenario where we actually often do get sleep studies for patients with RLS. I mean, I don't really think you need a sleep study for most patients with RLS. You certainly don't need it to make a diagnosis of restless leg syndrome, but perhaps they have RLS and they have sleep apnea. So sleep apnea, probably 1 in 4 people have some sleep apnea. It's incredibly common where you hold your breath. You do not know if you have sleep apnea. Okay, your bed partner may know, but you do not know if you have sleep apnea or not. And the only way to sort that out definitively is a sleep study. Maybe the RLS is controlled, but you're still kicking at night. You're still having those jerky leg movements, and those are actually subtly waking the brain up. So if your RLS is pretty controlled, but you're still just exhausted during the daytime, this would be a time to consider getting a sleep study. Okay. All right. Other things we might look at. So sedating medications. Well, they're on pregabalin. Pregabalin is definitely a sedating medicine. They're taking it the night before, but people metabolize medicines like pregabalin quite differently, and there's a chance that the pregabalin is bleeding into the morning and just making you feel a little dopey during the daytime. So the way to sort that out is, is the sleepiness, sedation mostly in the morning time. That's not the time we're usually most sedated, at least 15 minutes after getting out of bed. Depending when your alarm clock sets you off, I guess. But usually we get tired in the mid-afternoon. Okay, 2 to 4 p.m. is when people sort of peter out, and that's biological. Okay, I mean there's things that correlate with that. But if the sleepiness is just in the morning, well, maybe it's a hangover effect from the medication. I mentioned mood. Mood can definitely impact energy levels during the day, and you can have depression that results in sort of fatigue, sleepiness. Other simple treatments here, to try to wake people up, that non-pharmacologic, light, and then morning exercise. I hate morning exercise myself. I'm terrible at it. I'm just not my natural thing. But I do it sometimes to try to wake up if I have time in the morning before work. So these are things that you can do to try to, generally improve. Well, what about pharmacologics? Say you don't have an obvious reason for the daytime sleepiness or fatigue or tiredness or whatever. What are the options pharmacologically? Well, I mean, caffeine is an option to me. Caffeine is sometimes on a list of things to avoid with restless legs. I see no reason to avoid caffeine with restless leg syndrome. There's not a bit of evidence that it worsens RLS, at least when you take it in the daytime, morning. In fact, maybe it even helps RLS because, like I said, anything that makes you tired tends to worsen. So caffeine in the morning is fine from my standpoint, despite it being on some lists of things to avoid with RLS. There are stimulant medicines we use that seem to be safe in patients with RLS. Modafinil, armodafinil were medicines invented for narcolepsy. They seem to be fine in RLS. We recently actually did a study of pitolisant. I spelled that wrong on here, I see now. It's a T, not an L. At the beginning, pitolisant, which is marketed as Wakix. It's another medicine that was used for narcolepsy. And many patients with RLS really did like this medicine quite a bit, more energy. This one's difficult though because it's about $100,000 a year, and insurance will never cover it unless you actually have documented narcolepsy. There's even the stimulant medicines, methylphenidate or various amphetamine, Adderall type medicines. These all seem to be okay in patients with RLS. These are controlled substances. They're not to be used lightly, okay, because they're all stimulant medications. But we do use them sometimes in our patients with RLS, and they don't seem to worsen restless leg symptoms during the daytime. Okay, next case. This is one we'll spend the most time with because this is most of my clinic. 62-year-old female. These numbers are completely made up. I think I ended up with 60s every time here by chance. Diagnosed RLS at age 40. Started on ropinirole at age 48 with initial great response for 5 years. 5 years, no symptoms. But over the next 8 years, she started to get earlier onset of symptoms, worsening of symptoms. They increased the dose, and for a while this was satisfactory. She would get improvement, but 3 or 4 months later, symptoms would get worse again. Currently, she's taking ropinirole 4 milligrams 3 times a day. Pregabalin again was added in the evening at night. I will make a note in this case, ferritin is 61, iron binding percentage is 21. These are both normal, officially normal. So what now? This is the majority of my clinic these days. This is augmentation. Okay, so most people on this call are probably somewhat familiar with augmentation. This is associated with dopaminergic medications where they work great initially, but over time you push the symptoms earlier, you intensify the symptoms, you may get additional anatomy like arm involvement now. And if you miss the dose of the dopamine medicine, it's just a complete catastrophe. The symptoms are worse than you could ever imagine. So this is what happens with long-term use of dopaminergics and why the pendulum officially has swung away from using these first-line therapy because of this long-term augmentation. Now, there's lots of different numbers for augmentation. 5 to 10% per year of patients getting augmentation is bantied about. There are certain risk factors for augmentation. We can get into those in more detail maybe in the questions. But again, you know it when you see it. So what do you do in this case? All right, well, this is where it gets complicated. I guess I will preface this with a couple of years ago at the sleep meeting, Chris Early and John Winkleman, two authorities on RLS, and myself were giving a lecture at the sleep meeting. Basically, what do you do with augmentation? Although we all had, obvious similarities, like you have to stop the drug. After that, we had all sorts of different ideas. So I want to emphasize here again, all of this is kind of my opinion, okay? This is not set in stone. This is not based on scientific studies that show you the best way to handle this. All right, so first thing, can you play with the dopaminergics? Yeah, You potentially can, okay? Uh, can you switch, say, ropinirole to pramipexole? That might work, okay? That might work for a little while. I mean, put a gun to my head of the three main dopaminergic medications, which are here: ropinirole, pramipexole, and rotigotine. The three that are FDA approved for RLS. I think pramipexole tends to be the best, but in any one person that may be false. You also do have extended release versions of these medications. So there's a ropinirole extended release, a pramipexole extended release, which are generic, although they're not easy to get sometimes. And then, of course, the Nupro patch is a 24-hour preparation. So timing of dopaminergic medications makes the world of difference. And if you're just augmented a little bit and you're having symptoms at 8 p.m. and you're taking your dose at 9 p.m., well, you could probably take the dose at 7 p.m. and take care of that for a while. However, as my first bullet point says here, eventually, once you start augmentation, if you're playing with the dopamine medicines, that likely will fail eventually, okay? It may fail in a month, it may fail in 2 years. That's a big difference for many people, but that strategy generally will fail. So you can play around with the dopamine medications, but ultimately, in many cases, we have to stop them. That's the only way to improve augmentation long run. So what are the next steps? The first step, the second bullet point, I can't really emphasize enough here, although it didn't make it yellow. This has to be a thing, an event. You're going to have to pick a time to stop the dopamine medicine. You don't just say, okay, I'll do that tonight after seeing the doctor. You pick a time where you can dedicate a week to this, where you might have a pretty rocky week. Okay, I really can't emphasize this enough. You can't do this haphazardly. You gotta plan stopping the dopaminergic medications. All right. Next, IV iron if possible. So that patient's iron studies were all normal, but in my mind, they are low enough that if we can get away with doing intravenous iron, then we should do it prior to trying to stop the dopaminergic medication. All right. This tends to make stopping the dopaminergic medications much easier. There is, again, nothing set in stone about who can get intravenous iron. We used to do this very easily, but in the last year or so, insurance coverage has gotten much more challenging and difficult. Insurance probably would not cover intravenous iron for those numbers because they are officially in the normal range. Keep in mind, blood levels of iron are not what we care about. It's brain iron that we care about, and blood iron only somewhat resembles what brain iron is, okay? So intravenous iron, if at all possible. Let's talk about iron, digress here a little bit and talk about iron. First of all, well, what about pills of iron? Pills of iron are very ineffective overall, with the one exception is if you are severely iron deficient, okay? If your ferritin is like a 5, you will absorb iron very well. The problem is this, and I don't expect anyone to memorize this, but the body is set up, in homeostasis. It always tries to keep things in the middle, not too high, not too low. And iron regulation is no exception to that. The problem is we didn't evolve perfectly, okay? This evolved like most things in evolution. I don't hope I'm not getting too controversial here, to keep you alive from bacterial infections. Everything that goes wrong in the body can be blamed on keeping you alive from a bacterial infection, because for the vast majority of Homo sapiens, bacterial infections killed 90-some% of all people. So we're very good at that, but that has unintended consequences sometimes. The body evolved to cut off iron absorption when you're in an inflammatory state. When you're in an inflammatory state, ferritin goes up. Now, these days, we're in inflammatory states because we get old and we have arthritis and stuff like this, and that artificially raises ferritin. When you have a high ferritin, it cuts off the absorption of iron in the gut because bacteria needs free iron, and this was a strategy. We assume, no one asked the Celestial Design Committee, but we assume this was to avoid free iron for bacteria and as a way to kill bacteria in your body. Unfortunately, this wasn't when people were 75 years old, where everyone's ferritin goes up artificially. So uh, we do not absorb pills of iron very well unless our ferritin is quite low. There's a whole series of other things to improve iron absorption, being again a 3+ state, or ferric iron, having a little bit of an acidity to it. Iron sometimes comes with vitamin C pills to make it absorb. So there's a whole series of other things you can do to potentially help. Some of them I have listed here, but the main thing is your ferritin has to be low. And if you have a ferritin of 75, you're honestly wasting your time taking iron pills. You're just not going to absorb them. Okay. All right. So because of that, we frequently will switch to intravenous iron to sort of bypass this system. And there's a number of different intravenous irons out there. The most common ones that historically been used are the first two, low molecular iron dextrine, ferrocarboxymaltose, and ferroheme is now pretty popular. And again, that's because of insurance reasons, not because of medical reasons. Uh, what doesn't seem to work quite as well, and again, this is not based on a truly proper scientific study, but iron sucrose or Venafir doesn't seem to work as well. It's very different than the other preparations, and it ups your iron for about 3 days, and then you pee it all out. Whereas these other ones, it stays much longer. Keeping in mind, you have to get that iron from your blood to your body. So whenever possible, we do a very high dose. We kind of think if you need one big slug, not a whole bunch of little doses like they do if you have renal failure or something like that. That doesn't seem to work, but a big slug of intravenous iron prior to stopping the dopamine medicine, or again, as in treatment in general for restless leg syndrome. Okay. Okay, then what? All right, so you've picked your time. I have a week. I'm on vacation. I have to paint the walls of my house. I can do that all night and move around. So, if I have worse symptoms, then it's a good time to have worse symptoms. So usually we're going to add an opioid. Okay, now opioids have their own issues. Okay, lots of issues with opioids. But this is the only thing we've really found that can get people over the hump from stopping the dopamine medications. Um, Opioids have been used for a long time with restless leg syndrome. So this is from, what was it, 1683. The first good description of RLS I'm aware of by Willis, who was a famous English physician of his day. He has a bunch of things named after him in medicine. Leapings and contractures of the tendons, so restlessness, toppings of the members. The disease are no more able to sleep than if they're a place of greatest torture. He successfully treated this with opium. Okay, so he did a pretty good job. Okay, treating restless leg syndrome. There's a lot of different opioids out there. Okay, we usually use, personally, again, this is going to be my opinion, but I think the opinion of most RLS experts, we usually use one of two, methadone or buprenorphine. The biggest difference with these two compared to other ones is they're longer acting. Okay, because they longer acting, they sort of taper off themselves. They don't stop and result in this horrible withdrawal phenomena that shorter acting opioids like hydrocodone can, or even fentanyl type medicines can give. They are both officially used to get people off of other opioids. So again, one way or another, they seem to be less addictive or dependency forming. Addiction and dependency are two very different things, by the way. Addiction is more of a psychological term for a need for something, even if it is clearly deleterious to your overall well-being. Dependency is more of a physical, biological form where if you stop an agent, you get withdrawal symptoms. Okay, so opioid withdrawal results in just a miserable sort of feeling. People don't die from opioid withdrawal. Okay, they may wish they're dead. Okay, but you don't die from opioid withdrawal. You can die from alcohol withdrawal. Okay, that can actually kill you. But opioid withdrawal is just miserable. Okay. So we tend to use methadone or buprenorphine, which are these longer acting medicines. They both have some pros and cons. Methadone's nice because it's dirt cheap, okay? So it's 5 or 10 milligrams, it's always the same. Buprenorphine is a little more complicated to use because it's not a pill, not really a pill, it's sort of absorbed under the tongue, and they have all these different preparations with different milligrams. They're not interchangeable. So if you have one brand, you can't just switch that milligram to another brand, unlike methadone. It also sometimes comes with naltrexate, and sometimes only insurance will cover that. Naltrexate's probably okay for RLS, but naltrexate is blocks the effect of other opioids, and that's specifically used with buprenorphine for opioid withdrawals to get people off heroin and other stronger opioids. Cost is variable with buprenorphine. Okay, so there's some pros and cons in these. Buprenorphine is actually a slightly less controlled substance, meaning you can write refills. Methadone is a true hassle factor to prescribing this medication. You can't write any refills. Any physician can write methadone, okay? If they really tell you, oh, I'm not on a methadone registry, that's not really true, okay? Any physician can, you don't have to be in a registry to prescribe methadone, but that's an older law, but I don't think there's any state that requires that anymore, okay? But many physicians simply will not write drugs like methadone or buprenorphine for that matter, because there's such a backlash against chronic opioid therapies. And these are typically chronic therapies, and legitimately so, okay? I mean, I don't want to minimize the risk of opioids here, but in our population, the restless legs, I think we actually have very little issues with dependency or addiction. And we do have strict limits on the dosing. And again, we only use these sort of less addictive medications. But again, many physicians are not going to be comfortable writing these. All right, so hold on. Yeah, okay. So what do you do after you start the opioid? Okay, so we tend to revisit the, again, they pick the date, you've stopped the dopamine agonist, you've been on methadone, you have a few rocky days, but a couple weeks into it, you're doing better. And to be honest with you, with bad augmentation, even if you did nothing, typically by 2 weeks, you're doing better than you were at baseline. It's just a miserable 2 weeks to get there, okay? What do you do after that? Well, again, this is going to be completely a matter of opinion. Many of our patients just stay on the low dose opioids. I've had patients on methadone for 25 years. Okay, we've never had to go up on the dose. It's kind of a pain in the ass for all involved because of the jumping through the hoops to get the medication and the pharmacist snickering at looking at you funny and things like this. But so many patients just stay on these medicines. Sometimes you can, however, now go back to a gabapentin, pregabalin medicine. Whereas if you just try to switch a dopamine medicine to those medicines, it ain't never going to work, okay, if you're augmented. But if you're off the dopamine medicines, you may revisit that. And that's a theme for my next case. Okay, so last case here to talk about. This is basically after all three of those cases, what can happen next. 65-year-old woman, I really need to be more creative with my ages here. 25-year history of RLS, currently taking methadone, 10 milligrams in the afternoon and 10 milligrams at night. There was a history of severe augmentation. She was the case previously 5 years ago or something. She reported no benefit from gabapentin or pregabalin. She has had this gradual worsening of sort of a painful quality of restless legs now in the arms and the legs every night, causing severe insomnia. Says the symptoms are terrible, again, as bad as they've ever been. Okay, we'll even throw in maybe she had been on buprenorphine in the past too. Okay, so this is the toughest case. Okay, they've been augmented, you got rid of that, you put them on opioids, you consider kind of your strongest medication. Maybe that worked for a while, but now even that doesn't seem to be working. All right, so this is the toughest. I don't have simple answers or an algorithm for this case, but let's look at some things that could be options. All right, number one, I really want to emphasize here, reevaluate previous medicines. Why didn't they work? Okay, so there's plenty of examples of medicines that failed in the past that will work in the future, okay? Main reasons. So I alluded to, if you're augmented, okay, and you try gabapentin, again, it's a drop in the bucket. It ain't gonna work. I mean, I don't want to say, I don't want to say anything definitively, but it's not going to work well. However, if you're no longer augmented and you have not been on a dopamine medicine, that gabapentin may work fine. Okay. So you have to, I mentioned gabapentin failed, pregabalin failed. I didn't specify when she was on those medicines. If she was on those while she was on pramipexole, then I am all for reconsidering, one of those medications, even though I was told by the patient it did not work in the past. Okay. Plenty of other examples of reasons why this might be. The opioid medicines, for example, have very complicated metabolic pathways. And depending on other medications, you may metabolize those medicines differently. You also metabolize medicines differently as we age. You 10 years now is a different you than 10 years ago. Okay. So even if it wasn't an augmentation issue for these medicines to not have worked in the past, the same medicine may work again depending on other medicines that you're taking. The best example of this is probably tramadol. Tramadol is a very common pain medicine used by a lot of patients with RLS because it's a relatively easy opioid to get. It's a sort of a lower schedule, so you can write refills. And it's, again, most doctors are comfortable giving tramadol. Tramadol is a very weak opioid. However, one of its metabolites, the way the body breaks it down, becomes something called dimettramadol, which is a very, very potent opioid. Okay. Now, some people metabolize it mostly that way. Some people metabolize it mostly another way. And that can also change depending on what other medications you're on. Okay. If I would argue, most people that have a dramatic response to tramadol are people that metabolize it mostly through something called CYP2D6, which goes into this more active, much more potent opioid medication. Codeine is metabolized into morphine, okay, but only part of it. So morphine is a stronger opioid than codeine. Hydrocodone in some patients is metabolized to hydromorphone, which is a much more potent opioid. So again, different metabolic pathways in different people can explain some of the discrepancies of why medicines may work one time and not work another time being the same medicine. So reevaluate previous medicines. Just because it was not adequate 10 years ago does not mean it's not going to be adequate now. Okay, other things we might do is chip away at some of the other problems. So I'd mentioned a couple times insomnia worsens RLS. So that includes insomnia not caused by RLS. So anything that causes sleep deprivation will make your RLS worse. Anything that makes you more tired or fatigued will make RLS work. So sometimes we break down and give old-fashioned sleeping pills. We're not proud of it typically, okay? There's again also a backlash against using the traditional sleeping pills, the Valium, clonazepam, Xanax of the day, and even the Zolpidem type medicines, what's called the XYZ drugs, sometimes Ambien type medicines. These medicines are associated with all sorts of epidemiologic problems, including worsening cognition, in elderly patients. So there's lots of reasons we don't like using these, but they can work as a sleeping pill. And sometimes just knocking you out better will then improve the restless legs, even if they do not directly help the RLS. They indirectly help the RLS. So I'm not above using these sorts of medications. We most commonly use Zolpidem, which is Ambien, simply because it's so short acting that it's out of your system in 7-8 hours when you're getting up for the next day. Okay, and it doesn't seem to worsen RLS. Sleeping pills that are antihistamines, which are mostly over-the-counter sleeping pills, do tend to worsen RLS. There's other types of sleeping pills that can sometimes work very well. These orexin antagonists, so Belsomra is the brand name that people tend to know, Dayvigo, Quivik. These actually are not as potent sleeping pills as like the Zolpidem type medicines, but they also seem to work well in patients with restless legs. Orexin, which is a chemical that a simple answer, it keeps you awake, but a more complicated, nuanced answer is it keeps you stable in your wake versus sleep state, so you don't go back and forth. That is abnormal in patients with restless legs, so it makes some sense to use these medicines. And sometimes we have decent results with these medicines. Cost is a problem with these. They're all brand name drugs. None of them are generic yet. So I have a lot of problems getting these covered in many patients. So just treating the sleep, reevaluating medicines in the past, trying to help patients sleep are two things that you could consider. Now, I'm going to briefly go into final two treatments that are considered kind of newer, or I wouldn't say investigational, but the first is dipyridamole. So dipyridamole has gotten a little publicity for restless leg syndrome. Dipyridamole is a very old medicine. It's a blood thinner, okay? It's really seldom used as a blood thinner these days. This was Persantine, if anyone remembers that brand name, because it didn't work that well. Although it was commonly used with aspirin, and the combination of aspirin as a blood thinner and dipyridamole is still sometimes used. Now, this impacts adenosine in a fairly complicated way. Adenosine is of great interest in restless leg syndrome. It's really kind of a convoluted explanation, even to an expert like myself, how dipyridamole works through adenosine. Adenosine can affect dopamine as well, but there's some small studies that show dipyridamole can be effective in patients with restless legs. If you're on other blood thinners, I don't think this is going to be an option for you. If you're on clopidogrel or some other blood thinner like that, to me, I wouldn't be comfortable with that. But this is an old generic medication. It does have to be given. It's a super short-acting medication, so it's like 3 times a day for most patients. There are some long-acting versions that aren't generic of the medicine available. I have not had a whole lot of experience with this myself, but dipyridamole is something else that might be considered. And then the last thing I'll mention in just one slide, there probably has been a whole lecture on this in this forum, but is this perineal nerve stimulator. So this is an interesting device that stimulates the nerve kind of on the outside portion just below the knee, where the perineal nerve is very close to the skin. And the idea is it stimulates it just enough that you slightly sort of contract the muscles just a little bit, and that's like movement. I mean, people move to improve the RLS. There may be some stimulation going up towards the brain the other way as well. That's debatable. But this is available in some states. It's rolling out in my state in about a month, Texas. I do not have a sense of cost for this. I think it's going to be quite expensive, and insurance will not cover it for a while. And it also can only be used about 60 minutes. So it's designed for people to take, at night when you're going to bed, and then it turns off after 30 minutes. You can turn it on for another 30, and then it turns off at 30 again. And again, it was studied in just regular run-of-the-mill restless legs, not necessarily terrible RLS that's failed other stuff. So I don't have a good sense of how this works. But it's another thing that could be considered as an adjunct therapy for these, sort of worst of the worst cases. Certainly we'll try it when it becomes more available. But again, I don't have much experience with this myself, as it hasn't been available locally as of yet. Okay, so I think with that, I will wrap up. It gives about 15 minutes or so. I know there were a number of questions already, and I tried to address some of those questions that I saw before, but I'll turn it over to Carla, is it, to facilitate any other Q&A?
Great. Thanks, Dr. Ondo. First question is there a chance that Jornavax will help with RLS?
Yeah, so this is a new pain medicine. It's very interesting. It affects sodium channels. And this was in the news as really the first sort of unique mechanism as a pain drug in a long, long time. Frankly, the closest thing to this is probably lidocaine, okay, which also blocks sodium channels, but it blocks all sodium channels, so you can't take a pill of lidocaine and you won't breathe, or things like that. But this is much more specific, just in these sodium channels that are used to signal pain up through the neuro axis. I don't know. Okay. My suspicion is no, because RLS is not pain. All right. RLS, we think, is coming from the top down, not from the bottom up to the brain, despite the sensory component of RLS. And there's other sort of analogies where you try to block nerve signals, and it actually, in some patients, makes RLS even worse. So I I just do not know, but if you put a gun to my head and asked me, I would say I think the answer would likely be no, but I would love to see a nice little scientific trial with this medicine in patients with RLS.
Can refractory RLS due to augmentation from long-term DA use be treated with clonazepam to avoid opioids?
I've never had much success in getting people over the hump with clonazepam or other benzodiazepines, alprazolam, Xanax, Ativan. They're all pretty similar medications. I don't. I think it's not a terrible idea to try to get you over the hump as adjunct therapy, but typically this would be with something else. Okay, tip, if you take enough of a benzodiazepine, you likely, will fall asleep. If you take too much, you can die. Um, but even just a little bit of a benzodiazepine to relax you sometimes even worsens RLS. So I don't think they're particularly good medicines for RLS, but I did mention benzodiazepines as sleeping pills, okay, as an adjunct therapy. So am I against it? No. I think most people would still have a pretty miserable experience coming off the dopamine agonist with just clonazepam or other benzodiazepine and not trying anything else.
Next question is, do opioids lose effectiveness as a treatment?
Well, anything can lose effectiveness over time as a treatment, but our experience in general is that opioids treatment persists for many, many years. I mean, there is published scientific reports on this. The dose does not seem to have to go up over time. Okay, there's very good, scientific evidence for that for RLS, and that's different than pain. In chronic pain, the dose tends to eke up over time. We don't see that typically in patients with RLS. So, in any one person, can you lose effect? Yeah, and I went over some reasons. Make sure you're not on antihistamine now. There's some drug interaction that changes the way the opioids metabolized. Um, but in general, we have very good long-term benefit with opioids compared to dopamine agonists, where again over years, almost always the baseline symptoms worsen.
How does the timing of medications affect their effectiveness? So what if you're taking like Horizon and methadone, is there a certain way that you prescribe to your patients?
No, timing is everything. Okay, and I probably should have emphasized that with the reevaluation of previous meds. I mean, sometimes meds don't work because they're given at the wrong time. Again, if your RLS is terrible at 8 p.m. and you're taking a medicine at 10 p.m., well, that's not right. Okay, you got to get the medicine in your system typically before the onset. So yeah, timing is absolutely critical. Horizon's a really special case because it was designed to be a very slow release pill. And it's probably 5 to 6 hours after swallowing that pill that you get the peak effect. But any slow release, long acting medicine, I mean, if you're on pramipexole, ER extended release, that's going to take hours till you get the peak effect. So timing is absolutely critical with the medications, and it's something that always needs to be reevaluated. I mean, one of my first questions uh, typically are, tell me when your worst hour of the day is, tell me when your symptoms start to get going. That's the first thing in my mind when we're planning on the dosing and the timing of medications.
How do you manage RLS and Parkinson's disease when on a high dose of a DA, which is not helping?
Yeah, so this can be a tricky scenario in Parkinson's disease. So Parkinson's disease is treated with dopaminergic medications always. Okay, I mean always treated with dopaminergic medications, which are miraculous treatments for Parkinson's disease. They have their problems in PD as well, but you're always going to be on dopamine meds. Now, so I can get really really complicated on this, but RLS as a symptom is a pretty common thing in Parkinson's disease. There's Parkinson's disease patients have lots of weird sensory stimulus symptoms that come and go, and RLS is one of those. Now, that being said, there are people that have RLS for 50 years that develop Parkinson's disease, where they probably have what I think of as true, restless leg syndrome, Although I think there's actually evidence, believe it or not, that having RLS may protect against getting Parkinson's disease, and we've published papers on that before as well. But the problem is, you're using dopaminergic medicines for the Parkinson's always. So what we usually do is the gabapentin type medicines, pregabalin sort of medications, for patients with RLS and Parkinson's disease. I don't think there's no reason you can't use opioid medicines, but I think opioids in patients with Parkinson's tend to have a little bit more side effect issues than they do if you don't have Parkinson's. So the most common thing we do is the gabapentin, pregabalin, horizon sort of medicines. Another issue that comes up is Parkinson patients tend to have more iron in the brain, and that is argued to be a bad thing for Parkinson's disease. Okay, now I don't absolutely agree with that, but the consensus would be, and I still would not do this. I would not give intravenous iron in someone with Parkinson's disease, for fear that you could be worsening the Parkinson's disease in the long run. So that's another difference that can complicate things in someone with RLS and Parkinson's disease. So it is a complicated scenario. The simple answer is the gabapentin type medications, what we would typically use for that.
Okay. Is it better to use devices such as a TENS unit or compression boots in anticipation of RLS, or wait until symptoms start?
So sensory stimulation can improve RLS, and this tends to be vibration, pressure, heat. A TENS unit, in a traditional TENS unit, I don't think typically helps that much. But again, the nerve stimulate, this perineal nerve stimulates different frequencies, different power settings, and stuff like that. So not all TENS units are the same thing. Can you prevent symptoms from that? That's a good question. I would speculate no, that you would really treat the symptoms when they're happening. But again, I'm not aware of any scientific study that's ever looked at that, and it's not something my patients have typically told me. So it certainly is reasonable to do sensory stimulation when you're having symptoms. If some people want to do the experiment and put on these vibrating things or the pressure 30 minutes before they get symptoms and take them off then and see if the symptoms don't occur, I'd be real interested in hearing what the results of that are.
So what is the difference between the Nidra and the TENS devices?
Well, the nidra goes over the perineal nerve, which is a motor nerve, and that's a big nerve. Okay, TENS devices are are just sort of over the skin, and they're picking up sort of microscopic nerves. The power is much more in the nidra than the TENS units. Okay, and the frequency, the pulsatility is different. The TENS units are thought to just do with afferent is the medical word for coming up from, say, the feet to the brain, whereas the nidra is thought to be going efferent, which is same as affect and effect, which is going down from the brain, or in this case, the nerve, downward to actually result in a muscle contraction. So a TENS unit would not result in muscle contraction. But the biggest difference is the power settings are completely different.
Okay. Tell us what you know about the use of kratom or ketamine, kratom and ketamine for the RLS symptom management.
Yeah, okay. All right, so ketamine first. Ketamine is an
Okay.
NMDA drug used for refractory depression. NMDA is a receptor for a chemical called glutamate. Glutamate is actually the most common chemical in the brain. It's all over the place. And there's a couple of other NMDA type drugs that are memantine and duodexta and amantadine. I don't think there's there's no evidence, okay? No published papers on this. I've had two patients I can think of that had taken ketamine with RLS, and the bottom line is they didn't notice an effect one way or the other with that medication. Kratom is originated in Thailand, true kratom, and it is an opioid. Okay, mirbrentine Tizine, I think is the name. I might be one letter off on the actual chemical in true kratom. It is a straightforward opioid like heroin. Okay. In fact, this was going to be made illegal in the US years ago, but there was petitioning by patients and by, frankly, people that sell kratom to Congress, and they kept it legal. The problem with, well, I mean, again, it's an opioid, but marketed kratom could have anything in there. You have no idea what's in kratom, and usually they put other synthetic chemicals in the pills of kratom. I mean, it's the general problem with over-the-counter meds. You have no idea what's in there. They're not regulated in any way, shape, or form. But true kratom, the original stuff that came from Thailand, was a plant that's indigenous to Thailand, is just a straight out opioid medicine.
All right. So before we wrap up, I would like to know more about what you're working on, what studies you have going. Are you recruiting for any clinical trials?
We've finished a couple recently, but I don't have a clinical trial at the moment. The big, sort of the main clinical trial that's in the works nationally is a follow-up on the EcoPIPAM trial, which the RLS Foundation actually funded. This is an interesting medicine that blocks dopamine 1 receptors. We postulate that augmentation. Oh boy, how much background you want on this? So there's lots of different dopamine receptors, and they do very different things. In fact, they do opposite things. Okay, really, they do opposite things. D1 receptors are the opposite of D2, D3 receptors physiologically in how we work. And we think that people get augmented because they're upregulating D1 receptors over the time, and D1 receptors make RLS worse, whereas D2 and D3 receptors make it better. EcoPIPAM is a drug that blocks dopamine 1 receptors. And the idea is in patients that are augmented, you might be able to give this medicine and block the augmentation, or in long term prevent the augmentation, and you still get all the good benefits of the dopamine agonist medicine. So this would be like a pramipexole and EcoPIPAM. We did a very small, very, very small study, which was funded by the RLS Foundation, which was encouraging. Okay, it was too small to really get definitive, did it work or not work, but it was very encouraging, well tolerated. And based on that, there is a large national study starting up probably in about 3 months. All about 30 places will be enrolling for this across the country, looking at this as an adjunct therapy to other medications. So it'll be the first thing that's ever been looked at that's added on to other medications for restless legs. Like I said, there is zero data on once you get past, just a drug versus placebo. So adding a drug to another drug, we don't have scientific studies. So this is something we're very, very excited about. And hopefully we'll start by the summer of this year.
So I don't know if you can answer this, but I'll ask it this way. Do you know, or will you be the PI on the study?
I'm the PI for the study
Okay.
nationally. I'm not, I probably won't be recruiting here, although I might have one of my colleagues, because there's some conflict of that being the national PI. But I may or may not have one of my other colleagues that be a site here. That's still to be determined.
Well, keep us posted, because we would like to be able to announce it in Nightwalker's other media, so that people know that this study's available. And if they'd like to participate, that they can have the information to go forward with that.
Great, I will.
All right. Well, thank you so much this afternoon. We appreciate you taking time out of your day to be with us. And I want to remind everyone of our next webinar on April 23rd with Dr. Buckfuhrer on RLS and disability. Thanks so much, and have a great afternoon.
Okay, bye-bye.
Bye.